And now I want to introduce our dean professor, our eminent dean professor, Dr. Professor of Clinical Oncology in our department, to take his talk about metastatic familial breast cancer. It is stage 2.
First, I want to thank the organizing committee of the conference and Pfizer for inviting me to present this talk. I want to pay your attention to wait till the end because I will present a case, a very, very challenging case. And of course, I want your opinion for this one. All of us know that with metastatic breast cancer, we are not treating for cure, but lately we have a very positive presence concerning the overall survival. So we started to be very anxious and look for the hope still. Why not? Because in the past we are just looking for the progression-free survival and full stop, but now we are going for the overall survival. This is my disclosure. So these are the main outlines that I will cover. For the first one, in the first line metastatic. In the first line metastatic, all of us know about the Paloma-2 that use the CDK4/6 inhibitors with the AI, also the Parzival, which use the CDK4/6 with the fulvestrant. Because sometimes you, of course, agree with me that some of the clinicians, instead of starting giving the CDK with the AI, they go and give fulvestrant with the CDK. So if there is a difference, the second is if we go for this CDK in the second line, and also I will show real-world studies, and then this case of luminal A breast cancer. All of us know that, unfortunately, breast is the first in incidence as a new cases concerning the cancer cases, constituting more than 30% of cancer. And if we look here for the world, we will find, unfortunately, that here in Egypt, it has a very high mortality incidence, that it's 18 per 100,000 of the cases with a high mortality incidence. If we look for the incidence just 2023, we here will find that about in the females about 31% is due to breast cancer. What about the metastatic setting? Here in Asia and Africa, unfortunately, it has a very high percentage of mortality, ranging from 44 to 80%. This is not the situation in Europe or the United States. In the NCCN, all of us know that the aromatase inhibitor with the CDK or the fulvestrant, it has a category 1 as a first-line therapy. But not only this, it can be also used in the second line if we didn't use it in the first line. These are the history and the journey of the palbociclib since 2016 till 2023. And you find here different trials, and I will cover them. The first one here is the Paloma-2, and it was concerned to give the palbo with the letrozole versus letrozole alone as a first line. And they show here those cases that recruited were post-menopausal cases with no prior treatment for advanced disease. And they have to be at least from performance status 0 to 2 to be recruited in the study. and we have two arms. The arm that used the backbone with the letrozole versus the other one, which is the backbone, the placebo with the letrozole. The primary endpoint, of course, was the progression-free survival, and the secondary was the overall survival. And this is the results. It's a very promising curve that showed that there is a benefit, still not that much. When here they did the post-hoc sensitivity for the survival data, you have it better than the other previous one, of course, because the survival, to have any comment on it, you have to extend the time. It doesn't show early. When they look here for the Paloma 1 and 2, in those subgroup that had the disease-free interval more than 12 months, they had that this was more significant, favoring the use of the valve versus the aromatase inhibitor single agent. So the conclusion was that the Paloma 2, it met its primary endpoint, which was the progression-free survival, and also the secondary endpoint. It has a safety profile, and also for the overall survival, it was longer in the arm of the valve. For also the use of fulvestrant with the CDK as a first line, you will find here that this Parzival trial, it addressed this in using the valve with the fulvestrant versus the valve with the letrozole, and it also had its primary endpoint as the progression-free survival, and the secondary endpoint, the overall survival. When we look here, we will find that the median follow-up was just 32 months. So you can see that the fulvestrant valve or the valve with letrozole, they are nearly equal. There is no superiority or non-inferiority favoring either arms. What about this B-reality X? The B-reality X, here we are looking for the safety and the efficacy of the drug. They, as you see here, they did an overview of different trials from all over the world, from the United States, Canada, from Germany, as this Maria, Italy. Also, all these studies, they look retrospectively, and they use a certain method of statistics in order to see is the results that we heard about through the trials is the same when we are looking in real practice and see what happened. Yes, here they, when they looked for this, they found that, of course, the FDA approved the backbone with the endocrine treatment, and also in men, not only in females, and it can be given safely. Here, as I previously mentioned, they look for all the studies and the trials through these different centers in the United States, and they did it, of course, the data was retrospective in order to look for the overall survival, or for the secondary, it was the progression-free survival, what is called RW, progression-free survival. And when you ask me what do you mean by this, is they use specific statistical methods to analyze their data. You can here see when they looked for those patients who had visceral disease, and they took all of the cases without doing this statistical method, you will find that they are relatively the same. So this means that it didn't differ from the trial. The same situation was for the age and for the performance status. Also, what about the overall survival? If we look for the overall survival, we will find that those cases that we heard and we saw in the different trials, when the overall survival, it is nearly the same. You have here difference in overall survival, with which was significant, and the same one when they used this SIBTW or the PSM, which is different statistical methods to analyze these retrospective data. This is for the progression-free survival, the same situation. The unadjusted, what we need before doing these statistical methods, it is nearly the equal and the same, and they have the same statistical significance. So the conclusion that this real-world study proves that we have to support the use of BAPO in combination with aromatase inhibitor as standard care for first-line metastatic luminal metastatic breast cancer. What about the second line? And this was addressed in the Paloma study, where they gave the BAPO with the fulvestrant in one arm versus the placebo with the fulvestrant. And they looked for those cases that were pre or post-menopausal, and they progressed on or they had received endocrine treatment. It was accepted to recruit those cases that received one prior chemotherapy. And this, of course, affects the results afterwards. Yes, if we look here, we will find that the curve of the BAPO fulvestrant is superior than that for the fulvestrant single agent, and this was also in the hazard ratio was 0.72. The median overall survival of 39 versus here 29. So there is still a big difference. What about the progression-free survival? You will find here that unfortunately, because we have different patient population, in the Paloma 3, they accepted those patients who had prior chemotherapy, but in the other two trials, the Monarch 2 or the Mona Lisa 3, they didn't accept this. So of course, this patient heterogeneity and population affects the results and had different impacts. What about the safety? The elder, of course, we can imagine the elder patients, we can have different side effects and different toxicities of the drug to be faced. But those patients who have a cardiovascular disease, take care about the thromboembolic or the prolongation of the QT. Those patients also having the impairment in the liver functions, they have to be taken in consideration the transaminases, but fortunately enough that it is reversible. And lastly, any patient with comorbidities, of course, a lot of all of these side effects can be fixed. What about if the patient has neutropenia? Neutropenia is one of the very important side effects that we can have during this treatment, and this is how you can deal with it. If you have just a grade 1 or 2, that's to say that the absolute neutrophil count is 1,000 or more, so you can continue with no dose adjustment. But of course, if the patient has infection, please hold the treatment. And this is, if there is a grade 3 or 4, there is another maneuvers. Okay, when we look those patients who's just a couple of minutes in the other room, someone asked me if the patient in the metastatic setting and you are you have to decrease or do a dose adjustment. Does this affect the effect of the treatment? Does it affect the progression-free survival? And here is the answer. Sorry. You find here that there is no difference in the progression-free survival if this patient had reduction in the dose, even if it is just not more than one even dose reduction. And this is my case. I have a phone from one of the surgeon calling me, I will send you a case, but as he said it like this, ربنا معاكي. And this is the case. The case was presented by bilateral breast cancer, cancer in cuirass, as you all of us know, but nowadays we usually don't face such cases. The patient went to this surgeon 1 year before she came to me and before she came to him also, and he asked her, you have to be treated. But she refused and she went away. She came once again, denying that she had been presented before, and she asked for treatment in this situation. She had a very bad performance, she had pain, but fortunately enough, she wasn't in visceral crisis. And this is her sono mammography, as you see, with the thickening, diffuse thickening in the skin. Okay, when I took this biopsy, proved to be invasive carcinoma, luminal A, and unfortunately there was widespread bone metastasis, and of course this is expected. This is the photo I took for her after she received 6 months of the valvocycline. And of course, the general condition has changed a lot. The patient, this pain vanished, and also her quality of life regarding doing the home activities and all of this, being a female, of course, it started to be regaining once again. Also, when I do for her this sonography, you will find that there is a change. I can tell you in the previous one, due to the diffuse skin thickening and the edema, they couldn't see any solid mass in the breast. But after having this hormonal treatment, it started to appear. And this is just on October 2023. There is a improvement in the skin. Of course, she is on bone modifying agents. So my take-home message is that overall 30% of those cases, early breast cases, unfortunately, they will develop recurrence or metastasis. Also, metastatic is incurable, and our aim is just palliative. Managing the symptom in order to have better quality of life has to be our major goal in this setting. The Pfizer, which had addressed that there is superiority or non-inferiority if we started as a first line using the CDK with the fulvestrant or doing it with the aromatase inhibitor, CDK with the aromatase inhibitor. But I think, and maybe I will ask you after I finish, what's your opinion about this? Also about using in the second line, we can give still the CDK with the fulvestrant with those patients having no prior chemotherapy and they had better, of course, progression-free survival and also overall survival. This real-world studies, it emphasized that the ignorance with the aromatase inhibitor is associated with significant longer median overall survival and also progression-free survival in the first line versus the AI alone. There is no difference in progression-free survival if the patient was forced through his doctor or her doctor to reduce the value dose due to this neutropenia. Thank you. I have a question. What do you think in the first line setting, if we are choosing in between the value or any CDK, let us speak about it like this, any CDK with the AI or start with the fulvestrant with the AI? What do you think? Dr. Heba.
Thank you, Dr. Naveen. Very clear and simple and illustrative presentation. So the sequence of giving aromatase inhibitor CDK as a first-line metastatic disease depends on how far the resistance to hormonal treatment those group of patients. So in post-menopausal patients, it is very clear that we better use fulvestrant with CDK4/6 inhibitor because they already on the adjuvant aromatase inhibitor. If the patient presented as a metastatic disease, you have the complete choice to choose aromatase inhibitor CDK4 or fulvestrant and give it later on. This is a common clinical practice. But patients who are 2 years or more on aromatase inhibitor, we are obliged to give a combination of fulvestrant with CDK4/6. And I would like also, because this is Pfizer Symposium, I would like to highlight that valmocycline with aromatase inhibitor with fulvestrant تحديدا have been used in international study as neoadjuvant. I was part of this ICRG group, and we give this neoadjuvant endocrine treatment in pre- and post-menopausal ladies, giving them a chance to be treated only by endocrine treatment, and it proves very good. Maybe the result is 36 PR and CR after this neoadjuvant.
Okay, thank you.
Thank you for having and try to have an answer question.
Thank you, Dr. Naveen, for this excellent presentation. I have only comment that you said if you reduce the dose because of toxicity, the progression-free survival and the outcome will not be reduced. So why you are giving a big dose if smaller dose will have the same outcome and with less toxicity? Why we should start with 125 if we can decrease it and the outcome will be the same?
Because, of course, saying that it didn't affect the progression-free survival, but in our practice, when we are giving this medication and then we have to reduce it, we will wait until there is improvement in the neutropenia and you will return back to the full dose. Because, of course, as we said, logically speaking, if I can give a lower dose with the same effect, okay, why don't we do it from the beginning? Of course, there is the privilege to give the full dose rather than reducing the dose. And even in this table that I showed as a dose modification, and in every situation, and this is not only for the PAP, but maybe for other medications, of course knowing that whenever you can return back to the full dose, you have to go for it.
Dr. Naveen, thank you for your elegant presentation and thank you for a very good job with these patients to not give her chemotherapy as usual, to give her a combination of treatment. Consider the combination, I think the renal evidence from palbociclib are much attractive in results than the balloon 2 and 3 because they designed to introduce a more hormonal sensitive patients to receive AI plus palbociclib whenever the patient have timeline because these populations are included in the Manila 3 trial. They gave palbociclib plus fulvestrant upfrontly, even 40% of the study are timeline. That's why I insisted to give these patients palbociclib plus AI and keep fulvestrant for sequencing or to give it after progression as a second line because you have a chance with these patients and actually did that to have a very good response because she's hormonal naive, started palbociclib plus amoxicillin or AI whatever, but the response is there and the response rate are much more better than the patient progressed on AI. Any more questions?
The patient was 45 years old at presentation. She was premenopausal. She was premenopausal. She was 45 years old at presentation.
Yes, she was present and she receives, of course, electrolyte.
So why you didn't consider right? I don't know.
Me and the I also know I will answer because it's not only the premenopausal. You are always have to use the ribo. It can be given in the other with the other CTKs. Okay, so it's not a must because she is premenopausal. You have to go for the ribo. It's not a must.
I agree with you. The premenopausal patient can turn into postmenopausal. They give annual. My second one, the patient presented with bilateral breast cancer. Did you think of BRCA mutation? Because we have data that patients with BRCA mutation may respond less to CDK4/6 inhibitor. So would you consider doing BRCA mutation before starting CDK4/6 inhibitor?
Yes, of course you are right. But doing the BRCA, we have a challenge, unfortunately. So it's not that, and she was, covered, sponsored. So it's not that easy. Even if she's BRCA mutant, I can't do anything. She can't be given this medication,
But my question, Dr. Sabi, and if a patient is BRCA mutant, would you avoid giving CDK4/6 inhibitor based on the data that we have that patient with BRCA mutation sensitive? I don't think.
Rather, I think the premenopausal status, I totally agree with you, right is there, but in real practice, we found many patients, as already been said, respond to CDK4/6 disregarding the class of drug, because in the real evidence, they included patients in the trials, in the postpartum trials, to receive fulvestrant plus palbociclib in the 10A or AI plus palbociclib in the patients in the premenopausal status. And actually, in the Luna 3 and Mark 3, they included premenopausal patients in the population to receive fulvestrant plus palbociclib. That's your question about the age of premenopausal and what's that. It is 7 in the trial for all premenopausal, but there are other trials to include premenopausal patients to receive PARP or whatever this fulvestrant.
Thanks a lot, Dr. Sabi and Dr. Nabil, for this very nice, interesting case. I think Dr. Asad, she's right to highlight that if there is scanning present or the ribo present, it will be preferred according to the premenopausal first line, the LISA 7 and the OS data we have. But I think this case Dr. Nabil had presented, we base it all in the clinical practice and the only available in the breast cancer initiative therapy drugs is only the palbociclib, the only available. So we base this clinical presentation not in the clinical practice. Okay.
Any more questions?
Thank you, Dr. Professor Medin, for this informative talk.
I'd like to ask about this training case. If قدر الله she saw a progression of bowel arthritis, what do you prefer? Will you re-challenge with another CDK4/6 or another second line, as Dr. Sabri mentioned, the second line hormonal, or you challenge with chemotherapy? I want to know your experience with this.
According to the SCN, as I showed in the beginning, using the CDK in the second line, it's if you didn't use it before. Of course, there are trials addressing this, but still there is no definite answer. Okay, so this is not evidence-based, so I can't do it. Okay, so if she progressed, and of course all of us know that at any time she will progress because she's metastatic, and we're not aiming for cure. In this situation, if the patient is not in a visceral crisis, so there is still the role of the hormonal treatment in the form of fulvestrant, and you can add to it other aromatase inhibitor, or also after that we have this aromatase afinitor. So we have a lot of endocrine treatment, but at any time that she goes for the visceral crisis, of course I will stop it and I will go for the chemotherapy.
To complete answer to Praveen, I totally agree with her. Is the artist process is time to postpone chemotherapy. So you should go for sequencing treatment to avoid or to delay time to chemotherapy as early as possible, as much as possible. Because whenever you give chemotherapy, you have visible effect of sequencing of CD4/6. You have many options. You have big 3 mutations. The positive again can give a best trial. If you have a add-on trial, emergent estrogen mutations, you can keep the bubble and change the AI plus fulvestrant, keeping on the emergent estrogen mutations. It's a add-on trial. You can maintain, you can go for maintain trial to go for ribociclib plus treatment for the responded patients. It's a but it's best trial. To avoid time to chemotherapy as needed. Because if you are taking chemotherapy, you have more success story post chemotherapy, CD4/6 or fulvestrant.
Thank you. You mentioned a very interesting case, and I wish that first, Dr. Asa, yes, the evidence is there is Mona Lisa 7, لكن احنا في مصر وضحنا نحن بقى دلوقتي من سنتين تقريبا بنستخدم البعض، وفي الحقيقه والعشر اللي احنا بنستخدمه الجزء عشان الافيلابيلتي. الديلي براكتس لقينا في ريسبونس ولقينا اميزنج ريسبونس. طبعا مش هقدر اقول ان انا عندي دوكيومنتيشن ان انا according to the availability احنا البعض. Okay. First, second, Fergata Equeras on her right side, did this patient receive radiotherapy?
No, because fortunately, immediately after I started her treatment, there was this, the area and the nipple, they were ulcerated, but there was no definite bleeding. Okay, so and in this situation, if I'm giving the radiotherapy, unfortunately, she had this cancer ingress all around, even at the back. So it will be a very,
And this is the response.
Yes.
Of
and the back total resolution of this skin changes, total resolution. Thanks.
The secret Dr. Lubna about this patient is naive. It's a sensitive patient, didn't receive any hormone treatment before, because whenever you start AI, you have accumulated estrogen mutations over time. You have a resistant clones to the treatment. That's why the treatment is very effective.
Just a comment about using of ribo or whatever CD4/6. The data is very clear that the only one who showed overall survival is ribociclib. All of them showed progression-free survival. So regarding response, we see response with any one of them. But our main aim is the overall survival. Till now, the only one that showed overall survival is ribosome. I know it's not available, but if we take also into consideration that we have data that Zenola alone compared to ribo, the second line, give the same results. They don't try a lot with palbociclib, give the same result with Zenola when compared to Pfizer.